Okay, so today I'll be taking a few vitals. First off, I'm going to take Melissa's radial pulse rate. So for normal radial pulse rate, it is shows a minimum systolic of below 80 millimeters of mercury and is 60 to 100 beats per minute is the normal range. So what I'm going to be looking for is that it's regular and bounding and have a strong pressure there. So is it alright if I take your heart rate?
Yes. Yeah.
Okay, so I'm just going to ask for consent, which is good, and time for 15 seconds. Okay, so heart rate was 22 in 15 seconds, and you times it by 4 to make it 88 beats per minute, and it was strong and regular. And if there were any irregularities with her heartbeat, then that could show you any cardiac problems as well. Okay, so the first part of the respiratory assessment is going to be the respiratory rate. So what I'm going to do is just ask Melissa, you just sit there normally and breathe, and what I'm going to do is count her breathing rate for 15 seconds and obviously times that by 4 to get per minute. So if you just sit there and breathe normally,
Yep.
breaths. Sweet. So in 15 seconds I counted 4 breaths. So times that by 4, that makes it 16, which is within the range of 12 to 20 for normal resting respiratory rate. So the second part of the respiratory assessment is obviously the auscultation. So have you ever had an auscultation? Do you know what a stethoscope is?
I know what a stethoscope is.
Okay, so have you had a stethoscope down your shirt before?
No.
Okay, so a good thing to ask is obviously the consent because it's a bit invasive, so I'll ask that before I go. But what I'm looking for in the auscultation is obviously any abnormal sounds within the lungs. So that is the wheezing, crackling, stridor, or any rails, that's the one, and then breathing. So just going to jump right in. So check stethoscopes in. This is right, I just get down the shirt.
Yeah.
Okay, just take a deep breath in. So after that, I found that there's no abnormal sounds, which indicates normal lung function. While I was listening, I was watching for chest rise and abdo fall, which indicates good volume and depth of breathing. And she didn't present any shallow breathing or too deep breathing, no struggle to breathe, or a tripod position, which indicates good lung function as well. So next up on the vitals is Mel's blood pressure. So how I'm going to do that is first I'm just going to remove a bit of clothing, asking for some consent. So can I just pull up your arm like that?
Yep.
Here we go. Just go over top there. Have you had a blood pressure cuff on before?
Yes.
Okay, so you know the feeling?
Yes. Yeah.
Okay, that's good. You go put that down. This one up. Next, what I'm going to do is just chuck the stethoscopes on the medial aspect of her elbow or over the brachial artery. Find the beat. There it is there. Now I'm going to pump it up to where I lose her heartbeat. And go 1 beat per each stroke, turn it on, and then slowly come down. So what I got there was 110 over 80, 110 being systolic and 80 being diastolic, and those come within the normal range, the average being 120 over 80, with the maximum being 140 over 90. If you have anything higher than that, so systolic above 140, that is hypertensive, and a diastolic above 90. Okay, so today I'm going to insert the OPA. When we use an OPA, we do it with a patient who has a decreased level, a GCS level of 8, who is unconscious and not breathing, and who can't maintain their own airway. So there's sizes ranging from 000 to 4. So first I'm going to measure it. So you're going to start at the top of the mouth and measure to the bottom of the mandible. And how we insert it is just go from the top, halfway down, twist 180 degrees, and then push to the lips. Just nice like that. The complications of using an OPA in that it induces vomiting. If there's already vomit or blood present in the mouth, it can be quite difficult to get it in. The patient may bite down on the OPA, inducing like a gag reflex, or you could put damage to the oropharynx because the sizes could be different. Okay, so now I'm going to insert the MPA. Okay, so why we insert the MPA is in patients with a GCS lower than 8, they're unable to maintain their own airway, or it's inappropriate to use an OPA. So first of all, how we're going to put it in is we're going to lube it up first, because it gets a bit tricky to squeeze it in the till like yet. So lube it all up. And how we're going to do it is, again, first measure it from the nostril to the mandible, because it comes in different sizes, small and big, And how we do it is we're just going to push it in at a perpendicular angle to the face, down. If we hit any resistance, you can twist it a little bit and just slide it in, or use the other nostril. So once it's in, it just sits like that. You can use for suction or other kinds of stuff. So the complications of using EPA, nasal polyps, there could be bleeding in the nasal, you could do damage to the nasal cavity, or if there's any head trauma. So now I'm going to demonstrate how to use the suction. So first we're just going to test it. So turn it right up. This is after the start of the shift where we've done a proper test. So that sounded pretty good. Okay, so now next what we're going to do is tip the patient into a lateral position like shown here. Remove any chunkier vomits or anything out of that occludes the airway, and then what we're going to do is go in for the suction but not go too fast, so only as far as we can see into the oropharynx, and only suck as we're coming out and for less than 10 seconds in a circular motion. So like this. Down in, I can see that far. So 1, 2, 3, 4, 5. That's looking good, clearing all that out there. Sweet. So a few complications of using the suction is it induces vomiting. There's laryngospasms. You could get bradycardia from stimulating the vagus nerve right in the back. A bit of soft tissue injury, and that's all from inserting it too far or making soft tissue damage in the mouth. Okay, so next off I'll be testing oxygen delivery. Okay, so what we've got here is the oxygen tank, normally found in the back of the ambulance, and oxygen regulator. So first off we're going to check the Bodac seal, which is in the back there, so just check that that's a good seal, and it's going to create a nice tight seal to the oxygen. So how to put that on is we just line up the prongs, slide that down and tighten the crank, and just as it goes in we're just going to quarter turn tighten it to show that it's connected. Then we're going to open up the oxygen tank, and that shows about half a tank, and just test the flow rate. So yep, so that's still administering oxygen. Next off we're going to do is we're going to attach the acute mask. Now the acute mask delivers 6 to 8 litres of oxygen per minute and about 60%. So what we're going to do is turn the oxygen on first. It's about 6 litres per minute, and to get it onto the patient, just open it up. Elastic goes around the face like that. Pinch the nose just to keep a good seal around the face, and tighten the elastic just to keep it tight around the face. And just one thing to make sure is that you move the oxygen on before you put it on the patient's face. So now just taking it off to flush the regulator, I'll just turn it off. Close the oxygen tank, and then open the regulator again just to flush the last bit. So next up what I'm going to do is demonstrate the BVM or the bag valve mask. So obviously the first thing we should do is check for any leaks and check the equipment works. So how we do that is first check the bag. Yep, so that's all good, no holes in there, and then check this one as well. Yep, so that looks like it'll hold the air quite good. Now I'm just going to assemble it and hook it up to the oxygen at 15 litres per minute to inflate the bag. Now we don't actually have any oxygen, so I'm just going to attach it and pretend like there's 15 litres going through it. And on. Yeah, 15 litres per minute. Yeah, so there's a few, an acronym that I should go through to talk about obviously using the bag valve mask, which is MOANS. First of all, obviously the mask seal, so anything like beards or anything just affecting the seal onto the patient. O is obstruction, whether it be vomit or no teeth or teeth coming out or something like that. A is the age, quite old people have like sunken in faces, so that could affect the use of a bag valve mask. N is the no teeth again, so that, again if they have false teeth you have to take them out. And S, which is the sniffing and snoring, so which is the tongue or back of the throat, including the airway. So that's a good acronym to use just to check the effectiveness of the bag valve. So next what we're going to do is actually demonstrate it. So again I'll just insert the OPA first. Slide that down. And what we're going to do is use the CE grip, which goes around there like that, encompassing the nose and the mouth, and head tilting up, and watch for chest rise. So chest rise 1, chest rise 2. Now we ventilate 1 every 5 to 8 seconds, and watching for obviously chest rise, and if there's gastric inflation we can put a second party to put cryopressure on there, which just stops that gas inflation there. So one will ventilate. So 1 every 6 seconds. Cheers. Next up, I'm going to be talking about the Life Pack 12. So first thing we should do is just check the batteries and everything's all in the pockets. So first of all, the batteries, how you do that is just roll over the back, and in the back here are the batteries. You can push the little black button on the top of them and they both show full batteries, so just change them. And if you want to take them out, you can just push the button, there you go, on the side, and then put it on charge and then back in the machine when they're fully charged. So that's how you check the batteries. Next up, we're just going to check everything's in the pockets. On the left hand side you should have your CO2 lead, your SpO2, your non-invasive blood pressure and your ECG leads, and on the right you have your GTN, your razor, your test defib and your pads. Next thing I'm going to do is just run a check test or a user test. So how I do that is I'll just turn the machine on. It first comes off into electrode mode, so what I'm going to do is press advisory, use the selector knob to put it into manual mode, then go into options and use this again, the selector knob to go right down to the user test and press OK. So that's just going to do its own user test and take a few minutes to do that. Now that the user test is done, what I'm going to do is just tear this off, and it shows the user test has been passed, so that's good. And now the next thing up is we're going to do is a test defib. So what we're going to do is go into the right pocket here. You've got your test load on the side as well as your test leads. So we're going to do that, and we're just going to connect these two. Go into advisory. Select our energy, because it's only a test, we'll go down to 50 joules. Charge it up. So that's just the noise of it charging. And then administering a shock. So now it's delivered a shock, now we're just going to test that you can disarm the shock. So we're going to do the same thing again, down to 50 joules, charge it up. But what I'm going to do is press the selector knob to cancel it. There you go, so that's disarming that charge. So now that I've disarmed the charge, now what I'm going to do is take this off, and what we're going to do is put it into lead mode, and after I attach all the leads to myself, using myself as a patient. So now that I've got everything attached, what I've got is the 3-lead ECG. So a good way to remember that is the white's on the right with green below, and smoke over fire or red is left leg and black is left arm. I've got the SpO2 attached, which measures the saturation of oxygen in the blood, and the non-invasive blood pressure cuff. So what it's coming up with now is just heart rate in the top left hand corner. Just underneath that is the SpO2, and then showing the three different leads which measure the electrical activity of the heart at different angles. To change the leads between different views, what I can do is press lead and then use the selector knob to go down to either paddles, 3, 2, 1, 2, 3, or AF as well, so that's just different angles. So what we're going to do is just go into 1, 2, and 3, and that just shows 3 traces there. Next off, what I'm going to do is adjust the QRS sound, which is part of the QRS complex in the heartbeat. So what I'm going to do is use the selector knob to hover over the heart rate in the top left hand corner, press OK, and it comes up with an option to a QRS volume. Click into that and then use the selector knob to turn it up louder. This becomes quite useful for maybe when you're in the ambulance on your own and you're trying to monitor your patient from the back. So you can use that volume there. Heart rate's quite fast. And then use again the selector knob to just bring it down and off again. So, and if I want to go home from that menu, I can just press home screen. That takes me back to that menu there. Next, what I'm going to do is just look at the lead height or amplitude. So how I do that is again use the selector knob, go into one of the traces. Here we'll pick 1. Click the selector knob and it will show you different waveform, lead size and the type of lead. So what we're going to go to is down into size, and then it'll give you a range of sizes. So you can go up, which as you can see makes the amplitude a lot bigger, maybe easier to see when it's quite faint, or if you want it less cluttered, go down and a bit smaller. And again, what we still click 1.5, that's quite a good size, and then again press the home screen to take you back to the lead. Next up is just identifying the NIBP, which is the non-invasive blood pressure. So I've already got the cuff on, which you're going to have on the patient, and what I'm going to do is press the button which is just above LAMS on the LifePak 12, press that, and that'll start inflating the arm, make sure it's straight, and that'll give you monitor blood pressure. Sweet, so that's come up with non-invasive blood pressure, and what we're going to do next is just identify the CO2. So there's this one here on the side, and this orange one you screw into the top on the left of the LifePak in there, and that is just above the SpO2, and then you would attach this into your breathing mask, and that will just detect how much CO2 has been blowing off from each breath, which is quite handy as well. Once we've shown that everything's working, now what I'm going to do is just change the paper. Maybe you want to print off ECG lead. So what you do is just lift the tab, pull it out, and then just at each side, pull out the roll. So that's quite a full roll, so I'll put that back in. And you've got to pull it out, make sure it's with paper on the top or like toilet paper. So what you do is just slide that in the middle there, make sure there's a little tab off, push it in, click it down, and then that's the paper filled again. So just looking at a few of the other things, again we've got the pedals lead, so that will be attached to your defib pads. On the left you've got your 12 lead, so you plug that into there and you give a better view of the heart through a 12 lead. And in the back again you've got the stickies, which are used for the electrodes, and more paper that fills up the machine. So that pretty much sums up what to do with LifePak. They're pretty handy tools. And yeah, sweet. So first off, what we're doing is doing hemorrhage control. The first thing most important is obviously applying the gloves and the goggles because we're dealing with blood here. So it's good. So first off, what I'm going to do is just look at the wounds. Eli here has a laceration on his forearm. So what I'm going to do is just expose the limb, say if there's any clothing or anything covering it, so open it up. Use my saline to clean the wound and just put a little bit on the bandage. Then what I'm going to do is just fold up the bandage so it's the same size as the wound there and just apply direct pressure. So you just hold that Eli, like, yep. Next up, what I'm going to do is just grab one of the gauze bandages and you start at the top, keeping that pressure nice and tight. That's it. Just wrapping around the wound. If I wanted to tighten it or provide more tension, then I could twist the bandage around and then go over the top there, just provide a little bit more tension there. So just do that a few times, make sure it's nice and tight, and I'm getting all the edges there. Now if I put one of these on and the wound is still seeping through, then I can do this again with another crepe bandage and gauze pad there. So what I'll do is just shut off. They're quite tight here? Yeah, that's good. That's good, man. Sweet. Just to stop that bleeding there. So what I'm going to do there is I don't actually have any tape, but I'll grab some tape and then chuck it over there just to keep it nice and tight there. So following hemorrhage control, now it's going to be catastrophic hemorrhage where there's a bleed through an artery or it's quite uncontrollable. So that's when we use a tourniquet. So how you apply a tourniquet is you just slide it up 10 centimeters above the wound and mainly on a single boned part of the limb. So what we do is just wrap that and tighten it around there and then wind the windlass around and tuck it into here. So we know it's tight enough when the distal pulse disappears or the bleeding stops. When we put the tourniquet on, we write the time because this one doesn't come off until they get to hospital. We can also apply a second tourniquet if that one isn't holding, just to help off with that halting of the bleeding. There's a few other methods we can do. We can lift the arm or limb with the wound above the heart, which helps stop the blood flowing out of the wound, or also apply indirect pressure either using one of these under the armpit or somewhere else like that. So next up what I'm going to do is the fracture assessment and splitting. So first off we're just going to assess the patient and what's actually happened. So Eli, can you just tell me a little bit about what's happened? Thanks, man.
I was just playing basketball with some of the boys and came down on my leg and sort of gave way straight away. Instant pain, really hurt.
Okay, sweet. So first off what I'm going to do is just ask consent if I can just expose the limb and have a look. So is it right if I just slide your leg up? I know it's a bit sore. Yeah. You should be with me. Okay. Okay, that's all good. Okay, so what we're going to do is just from the history and using the acronym PLUSTIS, I'm just going to determine the likelihood of it being a fracture, so that's just looking at the pain. Obviously the pain's there, any loss of function, whether it's unnatural, irregular, or there's a deformity, or there's any swelling with the limb. So obviously looking at there, it's quite red and swelled, and it's complete loss of function there, so it's quite a high likelihood of it being a fracture. Next off, what I'm going to do is just assess the cardiovascular and neurological integrity of it. So looking at it, I'm just going to do capillary refill as one. So it's in the centre of the foot, 2 seconds holding, for 10 seconds, sorry, and then see if there's capillary refill. I know it's sore, but bear with me here. Okay, so cap refill is about 3 seconds, which is, it's not bad, it's under 4 seconds, which is pretty good. Obviously looking at the colour and whether there's a pulse or not. And for the neurological, I'm going to be doing the feeling and the movement in it. So can you move your foot at all? Can you feel it if I do this?
Yeah, I can feel it.
You can feel it, so it's still there and still integrity, but it looks pretty sore, so maybe a fracture there. What else I'm going to do is a good indicator is just compare the other limbs. So I'm just going to slide this one. Is it okay to slide that up here? Yep. Sweet. So looking at both those limbs, his right leg looks quite red and inflamed compared to the left leg. So that's quite good there. So out of 10, 0 being the worst pain that you, 0 being no pain and 10 being the worst pain you've ever experienced, what is the pain on that scale there?
It's about a 7.
Yeah, so Alright, so the pain relief that I've chosen to use today is methoxyflurane, which isn't exactly in this, but comes in a 3 milliliter little ampoule that you tip in the top of the green whistle here. Now it is used for severe pain, which is above a 5, so 5 to 10 on the pain scale, and it's the green whistle. So what we've got here is just the mask on the front here and a charcoal on the top for continuous breathing of that pain relief, and that's to ensure that no fumes are let off anywhere else. So before I give it, there's a few contraindications that I can use before I should administer this. So I just got to ask the patient, do you have any renal impairments that you know of?
No.
Do you have any personal or family history of malignant hypothermia?
No.
Nothing like that. Can you nod your head? You obviously can obey commands. And have you ever had methoxyflurane in the last week?
No.
Okay, so they are covered all the contraindications. So I'm going to just administer this. So what you're going to do is just breathe continuously through the mask.
Okay.
You may feel a bit nauseous or a bit drowsy or lightheadedness, but that's okay. There's a few side effects of that one there. Okay. So you just halfway at that one. Yeah, sweet. So now after administering pain relief, I'm just going to ask again to make sure that the pain's decreased. So Eli, could you tell me again on the pain scale, 0 being no pain, 10 being the worst pain you've been in, what pain are you in the moment?
Like a 2.
Like a 2. Okay, so that pain is bearable, so we can now splint his leg. So first we've got to size up the splint. So I'm just using cardboard splint, which is found in the back of the ambulance. So using for expected distal leg or the tibia-fibia fracture, I'm going to use the leg cardboard splint. So I've already sized one up and taped it all together. So that's that one showing there. For a bit of comfort, I'm just going to chuck a towel down the middle, just so it makes it a bit comfortable. Okay, so Eli, what I'm going to do, just good to ask for consent again, is you're going to lift your leg up, I'm going to grab your ankle, and we're just going to slide this under, okay? So I need to secure the limb so it doesn't move anywhere and cause you more pain. Is that alright?
Yep.
Okay. Okay, so on lift, we'll just slide it up nice and gently. Okay, ready? Lift. Yeah, nice and easy there. Sweet, so now what I'm going to do with the splint is both support and immobilise the fracture. Sweet, so now that I've supported it and immobilised it, it shouldn't cause him any more pain moving it around. And after I've done that, I'm just going to reassess the cardiovascular and neurological integrity. So now I show that the colour is the same as before. The cap refill, which tests that now. Yep, so the cap refill is about 4 seconds, that's alright. And the neurological, mate, so can you feel that there? Mm-hmm. Same as before? Okay, sweet, because sometimes putting on the splint, it can cause extra blockage of any arteries or blood getting to the distal end of the broken limb. Yeah. So now after we've taped that up and it's all good to go, we can be ready to transport. So if you're ready to go, that's alright? Yep. Sweet, and that's splinting. So next up I'm going to be talking about the C-collar. So obviously a few things to go around the C-collar before I actually put it on. The first off is that being the Nexus rule. So that's the National Emergency X-ray Utilisation Study, which just talks about a few pointers on when to use the C-collar. So a C-collar may not be required if the patient has no cervical spine tenderness, if there's no signs of intoxication, if the patient has a 5 out of 5 verbal on the GCS scale, there's no neurological deficit, and there's no distracting painful injury with it as well. So it's just when to use it, and now I'm going to be attaching. Okay, so now I'm going to be applying the C-collar. So first of all, it's just a good thing is to ask for consent. So obviously I'd ask them, alright, I'm just going to chuck the C-collar on, okay? It's just going to keep your neck and head stable, and it is quite tight, so just be with me there. While that's happening, we'll have an offsider here, so Jasmine, if you just jump in and put his head into neutral alignment, that's good. So next off, a few things before we put it on is we're just going to measure it. So how you measure it is from the top of the shoulder here to the base of the chin. So it's about 3 fingers, and how we do that is just measure it off the blue plastic and then to the cross-bonding hole. So yeah, that looks about right there on the short setting for this mannequin. Now we're just going to bend it a little bit just to take out a bit of resistance when we're wrapping it around their neck. So that looks good. Now what I'm going to do is just gently slide under. Yep, you're doing good there, Jasmine. Just hook the front yellow underneath his chin and then tighten. Yeah. We can adjust the C-collar after we put it on, say it's not a good fit, too small or too long. We can take it off, readjust, and put back on. And just as I put that on, I can put a towel. There we go, just underneath the head. Oh, a little bit more. There we go. And then just a bit of support there. Does that look in neutral alignment from you, offsider?
Yeah.
Sounds good. So that's C-collar. Oh my god! First thing I'm going to look at, check the dangers. So hear, smell, or see any dangers. Dangers are fine. Sir, can you wake up for me? This is not responsive. Now I'm going to check his airway. No, there's nothing blocking his airway. Now check his breathing for 10 seconds. 1, 2, 3, 4, 6, 7, 8, 9, 10. He's not breathing and he's pretty grey colour. Can you start cruising, please? AT1 calling comms.
Yeah, go ahead, AT1.
Patient is R49 requesting R50 AG.
Roger that.
Next what I'm going to do is attach the AD. Just keep on, patient's doing well.
Analyzing heart rhythm. Do not touch the patient.
Stay clear.
Shock advised. Charging. Stay clear of patient. Deliver shock
Clear.
now. Shock delivered.
Yeah.
Pause. Start CPR.
Next thing what I'm going to do is attach the oxygen and get some breathing going for him. So we use the bag valve mask at 15 litres per minute. Yeah, doing well. Okay, so when you get to 30, tell me and I'll explain.
5, 6, 7, 8, 9, 30.
Chest rise 1, just tilting the head back and creating a good seal. Chest rise 2, start compressions again. Does anyone know the patient? I'm just going to ask around, see if anyone knows him, SCSC collapse or anything like that. Maybe help out about what he's going through right now. So we'll go through that. So when you get to 30 again, you tell me. You can use the MONS acronym as well to assess the BBM. So it's like the mask, obesity or obstruction. Chest rise 1, chest rise 2, keep going. Yes, the MONS acronym, mask, obesity, age, whether they have teeth or not, or he sniffs or snores, just blocking their airways, they can be assessed as well. Compressions are good, so it's going to be 30 compressions for every 2 breaths, and about a third of the chest being pushed down. Doing well, that's good compressions.
Stop
Rise
CPR.
1, rise 2, hands off patient.
Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause. If needed, start CPR.
How she showed no yeah. Don't worry. I'm gonna shoot too.